So first of all, our CME objectives, which were also circulated to you in advance, given on the left side, and on the right side a disclosure. So I've been working on a research project for about the last year and a half, primarily with Mike Astin here in the department, and we've received some funding for that from a company called CareCore National, which develops utilization management programs for government and private healthcare payers. So, well, the subject today then is costs in the healthcare system, and particularly laboratory costs. So I've just, to set the stage, a figure from a recent New England Journal piece that shows something that I think we're all familiar with, that healthcare costs have been growing much faster than the growth of the GDP as a whole. So now we're up to about 17% of GDP being devoted to healthcare. And then within that, you can see that the federal growth rate, federal spending for healthcare has been going up even faster. So certainly the federal government is taking an ever closer look at healthcare costs and saying, can we control these in some fashion? So. But the GDP statistics are kind of abstract, and it's fairly easy to sort of let it kind of go over your head. But I think that for many people here in this room, there are things that kind of bring it a little bit closer to home, and certainly around the country, many people have been severely affected by this if they've simply lost their health insurance and then have to pay out of pocket. But even for the large majority of people who still have employee-sponsored health care, what they're expected to pay has been rising over time. And this is sort of what I've just given an example from a state of Washington health care plan that I think some of you in the audience use. And you can see that the costs, the monthly premium for the employee has been rising, and maybe it wasn't so bad back in 2006, but now we're getting up into some fairly serious money here. So it's affecting people. And then also in the audience, we may have undergraduates at the UW. We have faculty and staff in our medical technology who are teaching undergraduates, and perhaps some of you are parents of UW students or parents of recent graduates, and we're all aware that state funding for our university has been severely cut back. And it's not that the state is sort of purposely trying to hurt us, but simply, as pointed out by this article by Peter Orszag, until recently the budget director in the Obama administration, as tax revenues drop during a recession, states have to cut back somewhere, and because medical care costs are rising in Medicaid programs, they have to look somewhere else. And so fundamentally, rising healthcare costs are something that are having an impact in many areas, including our own lives. So the title of my talk sort of presupposes that we should control laboratory costs, but I think it's worth asking, at the outset, well, why should we be worried specifically about laboratory costs in the whole healthcare system? So on the left-hand side, these would be reasons why you could argue that this isn't something that really needs a whole lot of attention. First of all, it's a very small fraction of total healthcare costs. Roughly 4% of healthcare costs go for laboratory. Laboratories can say with great truth that they are really the leaders in improving efficiency in the healthcare system. There's probably no other area of the healthcare system where the per unit cost has been decreased so dramatically over the last few decades. And laboratories are leaders in introducing new testing technologies such as genomics that are going to have significant contributions to improving our health. But on the other side of the table, I think somebody who takes a different point of view would say, well, granted the costs are relatively small, but on an absolute scale, these are not insignificant sums. And from a practical political standpoint, every part of the healthcare system is going to be scrutinized as cost concerns increase. And then ethically, I think that no matter whether the expense is big or small, we shouldn't be wasteful in what we're doing. And so And then finally, it's true that new technologies often enter the healthcare system via the laboratory, but just because it's new doesn't mean that we should do it. And I think that we can think of examples of technologies that have kind of come into widespread use before they were really fully evaluated and have become expensive and may actually have had a net negative effect rather than improving health. And some of the recent controversies about whether prostate-specific antigen as a screening test is really worthwhile or are sort of an indicator of some of those issues. So personally, I kind of come down on this box on the table. I think that whether we like it or not, we're going to have to look at healthcare costs in the laboratory, and we want to approach that in an intelligent way. So this is how lab spending breaks down, roughly speaking, depending upon exactly which data set you look at. Roughly a quarter to a third of spending is in surgical pathology, and these groupings are based on CPT coding. And then the rest of it is various areas of clinical pathology is indicated here. And now BRCA1 and 2 testing obviously is not a lab discipline per se, but I put this on as an example of a new type of testing that's come along recently and has increased fairly dramatically in cost. So this is the kind of thing that sort of gets the attention of the health insurance plans as they're looking at laboratory and seeing something like this coming up in a major way. So what are the factors leading to cost growth in the clinical laboratory? Well, many of them are sort of shared with other parts of the healthcare system. I mean, fundamentally, perhaps most important underlying effect is simply that patients and the physicians and other providers taking care of them, they want more testing. They want more of existing testing, more new testing. So the demand is there. And then we've already touched on new technology, which then is put into use sometimes without a cost-benefit analysis. And then there's sort of features of our healthcare system in this country. It's fragmented. So often there just aren't incentives there for cost control. And coding and reimbursement systems, as we'll see later on, can encourage overutilization and overbilling. And then particularly in laboratory, there's a phenomenon that niche labs can use aggressive marketing or techniques like patent monopolization to monopolize certain testing markets. So all of these are factors that we will be contributing to the growth in costs. And this is just looking at that last point a little more in detail. This is publicly available information for publicly traded companies that are niche labs in particular areas, and I think most of you are familiar with what these labs do. And as you can see, for the most part, they're showing a very large annual growth in revenue. The folks at Berkeley Heart Lab probably aren't feeling too good about things lately, but everybody else is doing pretty well. So the mere fact that the number is going up doesn't necessarily mean that the testing is not needed, but the point is that, in certain areas at least, laboratory tests are rising, costs are rising very rapidly. Okay, so now I'd like to sort of go on to some of the research that Mike and I have been doing, and this is just a reminder that academic research has been going on for a long time. And so the term that we now use, academic or academy, had its origins from Plato, the Greek philosopher. And so he had a school in a beautiful olive grove somewhere outside Athens, where he met with his colleagues and his students to discuss issues both temporal and ephemeral. And anyway, here's Plato, and this is his model of the universe down here, and he's talking about it with people who are having various reactions to the discussion. Anyway, so this is kind of a sort of a low-budget thing, just people sitting around talking. But it can have big impacts. So I think what we'd like to do is have a sort of an academic consideration of some of these questions, but with a view towards ultimately, we hope, having the ideas kind of going back to the city of Athens to have an effect on the wider society there. So, as I mentioned, this project I've been working on with Mike Astian, another faculty member in our department, has been funded in part by a company that works with third-party payers, and so their questions have been, what is the nature of, how are the costs distributed, and are there things that don't seem to be cost effective in the laboratory testing area? So what I'm going to do is give some examples in the talk of things that we found that where there seem to be expenses that are probably not justified in laboratory testing, and then show how these expenses could be managed at the third-party payer level. So I'll cover most of these topics with specific examples of data that we've found. Sorry, okay, get the mouse back. And we'll get through most of these, but these last couple here, we won't really have time to talk about those. But the point is, there's a variety of sort of tools in the toolkit, so to speak, for an insurer to try to manage costs based on some sort of medically valid analysis of what testing is needed and what testing is not needed in various circumstances. So the first thing that comes to mind when you think about insurers managing medical costs is pre-authorization, and that's something that works well for very expensive things like a high-end radiology procedure or expensive oncology drugs. You can establish criteria of eligibility for the test or treatment, and then physicians have to submit information to determine whether or not their patient is eligible. So that certainly works, and that has been applied already. I mentioned BRCA 1 and 2 testing as a very expensive individual test, and that fits the model pretty well. It's a very expensive test. It's easily identified with a unique billing code. There is lots of research, lots of clinical experience to indicate what the risk factors are for having a BRCA 1 and 2 mutation. So you can establish a good model which has clinical validity for predicting the likelihood that somebody is going to have a mutation. And then another important practical point is that this testing is elective, at least sort of in the short time frame, and you don't need a fast turnaround time. So there is time to submit information, get pre-authorization, and then carry out the testing after that. But when you think about it, most other lab tests are going to fail that model for one or more than one reason, that a lot of lab tests are in fact, very few lab tests are in this range of $3,000 plus per test. There is often a need for rapid testing or you may have a perishable sample that you simply can't sit around and wait on while you're getting pre-authorization approval. And then a particular problem in the molecular testing area is that the lack of test-specific identifiers, so that if you have a policy, you can't necessarily enforce that because you can't really identify the particular molecular test that's being ordered, at least as it comes through the claim system. So let's look at some other approaches to managing laboratory testing. And the first example that I'm going to touch on is cystic fibrosis carrier testing. And this is a very common autosomal recessive disease. The gene was discovered a little more than 20 years ago, and DNA tests were developed shortly thereafter. And so we've been offering testing since 1989 in the department. The testing has gradually improved over time. So by the 1990s, there was a sufficient clinical and laboratory data base to indicate that population screening was at least technically feasible. So there were several pilot studies of carrier screening in actual clinical populations, and the conclusions from that was that this could be offered in a clinically useful manner, which would have a beneficial health outcome. So there was an official committee of geneticists and laboratory directors and obstetricians and others that recommended population carrier screening in 2001 based on a panel of, it was originally 25 mutations, but it was adjusted down to 23 a few years later, and this is the current value. So this has become a very commonly ordered test in the United States during routine prenatal care, something on the order of 1 million tests per year. So that's fairly significant then, considering that this test, that the list price could be in the hundreds of dollars at most centers. So this is one that we thought would be worth evaluating to see if there were any opportunities for improved utilization or cost savings. So technically, this test is one of the more complex tests done in the routine molecular genetics lab. The CFTR gene is pretty big, about 250,000 base pairs. So there's a lot of regions that you have to amplify, usually by PCR. And then most of the off-the-shelf commercially available test methods use oligonucleotide probes in some fashion to test for the mutations or the corresponding normal allele at that particular base pair. So there's usually about 15 PCR amplicons and something over 23 mutations in most test panels. Okay, but now coming to the billing system, this is an example where the coding and billing system tends to encourage sort of overuse and overbilling, I should say, because molecular tests, for the most part, with a few exceptions like BRCA1 and 2, don't have specific CPT codes. So what you have to do is you have to look at your test method and look at the steps in your method, and then you code a particular code for the step in your procedure. So in the case of a CF test, the first step is to make DNA from the blood sample. Then you amplify it by PCR. Then there's some sort of separation technique that's used, then some way to identify mutation, usually with a cocktail of oligonucleotide probes, and then interpretation and report. So the way that the coding system works is that you have 1 unit of the code for each time you do something. So making DNA, that's simple enough. You only do that once per patient. But then when you're talking about PCR, as I said, it's a big gene. You need a lot of amplicons. So you can bill for 15 units of this code. And then likewise, for identifying the mutation, it's technically compliant. It's perfectly okay to bill for 23 units of this code if you're testing for 23 mutations. So you can do the math yourself and see that even though the per unit reimbursement according to Medicare is not that large, you can rapidly get up into some pretty big numbers when you have these high numbers of units. So really the coding system is creating incentives for labs to test for a lot of mutations, and even more than 23 mutations, to increase the number of units billed. So how does this actually work in practice? I mean, is this really is this having an effect out there? So here we received a data set from a large commercial insurance payer in the eastern United States from our collaboration with CareCore. And this is from 2008 data. So we were able to identify cystic fibrosis testing in this data set from a number of different laboratories, and then figure out what were the laboratories actually being reimbursed for this testing. So as you can say, 3 fairly large laboratories received this average reimbursement for the CF test. So an average of those 3 of $485. And it was my reaction on seeing this, just running a lab that does this, that this is unreasonably high relative to the actual cost of doing the test. So you can get a sense of what's a sort of a more, quote, reasonable price for this by looking at what a reference lab would sort of bid for this business as a reference lab from a smaller place that wanted to send the test. So this is just one bid price in a system that we have access to of $176. So you could quibble about 175, 200, 225, but the point is there's a pretty big difference between that and what these labs are receiving. So I think that what that's saying is this test has an unreasonably high margin in the current market, and this kind of reimbursement is simply not justified relative to the technical complexity and the time and effort involved in doing this test. So what to do about it? Well, as I've said, this is largely because of the use of these nonspecific or molecular test CPT codes. So if you just work within the current system and we continue with those codes, there's several things you can do. I mean, first of all, you can say that payment would be limited to the 23 mutations in the standard panel, because some labs offer much bigger panels and they bill for bigger panels and get reimbursed for that. But the ACMG recommendation is really very well thought out, and it's been reaffirmed in their subsequent statement a few years later that really the 23 mutations is a clinically appropriate number to use in this setting, and that adding more mutations adds very, very little to the mutation detection rate and doesn't really, is simply not justified in sort of a cost-benefit analysis. So that's one step that one can do that would be very consistent with recommended good clinical practice. A second step would be to say there really are economies of scale in this test, that if you're doing multiplex PCR, 15 reactions in one test tube, it doesn't cost you 15 times as much as doing a single PCR reaction in one test tube. And the same thing with the probe analysis, is that the assays that are commercially available, basically all the probes are there in one tube, so you don't have to have 23 tubes or 46 tubes to test for one mutation. So clearly there have to be economies of scale which are not really recognized by the coding. So there could be either a per unit discount for multiple units, or you could come up with a test-specific CPT code. And sort of rumor has it that the AMA is working on that in some highly secure underground bunker in Chicago, and we will be hearing the outcomes of that in a few years. But anyway, and that's sort of what's been done for some of the molecular infectious disease tests over the years, where they used to be coded with this nonspecific system, and now for things like hepatitis C and HIV, there are test-specific molecular codes. Perhaps more radically further down the road, there already is a sort of a standard obstetric panel which puts together the tests that are ordered in routine practice. And so one could say that, maybe further down the road, we just need to bundle the cost of CF testing into other things like, rubella and ABO typing and so on and so forth. Okay, so that's CF. And now I'd like to turn to a different area that we started to notice when we were looking at molecular testing in the database and seeing sort of what the pattern was for testing for some of the molecular infectious disease. And so vaginitis is a very common problem in primary care practice, many patient visits for that. And I should say in this section that Mike and I have benefited greatly from our collaboration with Dr. Linda Eckert in the Department of OBGYN here at the UW, and she's a clinical expert in this area. And this is not something that's necessarily, you can't necessarily get a quick etiologic diagnosis from a clinical exam. And so the number of molecular tests for female genital tract infections has been increasing over the years. And so at first glance, this seems like this is kind of a better way to go than a traditional evaluation. And then it doesn't require a microscope or skill in interpreting microscopic images. So based on current practice guidelines as summarized here in this ACOG bulletin and by a paper by Dr. Eckert and her colleagues in the New England Journal a few years ago, you can classify the tests that are being done into two categories: ones that are recommended for routine primary care evaluation of this condition, and ones that are not recommended. So everybody agrees that testing for chlamydia trachomatis and Neisseria gonorrhea is appropriate. There is although the microscopic test would be traditional for trichomonas, there is a DNA probe test that you could argue would be appropriate, and then herpes simplex virus. But over here, there's organisms that are there, and then from a research standpoint, the presence and relative abundance of those may be useful in terms of establishing etiology. These are not sort of first-line tests that will be useful in the routine workup of every patient that comes in. So these can be classified as non-recommended tests. So we looked in a database of insurance claims, and this is quite a large one, about 3.5 million people across the United States, and many laboratories are represented. And we used ICD-9 codes to identify lab testing associated with patient visits for female lower genital tract infection, and then we identify the tests that were performed based on the CPT coding. So what you could see then is you can see lots and lots of visits, over 200,000 patients that came in with one of these ICD-9 codes. And of that group of about 200,000, roughly 40% had at least one molecular test performed on that visit. So if you then say which ones fall into that recommended list and which ones fall into the non-recommended, about 74% of the visits where a test was performed, only the one or all of the recommended tests was done. But about 26% of the visits, tests were done that were not on the recommended list, either in addition to these or simply non-recommended tests only. So there's quite a lot of testing going on that doesn't conform to clinical guidelines. And this is not inexpensive because, again, this is a very common complaint. Lots of office visits for this. So if you look at the cost, then it roughly is proportional to the test number. So about 76% of the total spending would be on recommended tests and about 24% on non-recommended tests. And then if you look at it just at a sort of a cost per visit at the level of the individual patient, that if you just have the recommended tests for a visit for this clinical condition, the average cost was about $61 per visit. If you had, in addition to that, the non-recommended tests added about $66. So basically, the average cost of molecular testing per visit is more than twice, goes up about 100% if you start adding on these tests. And then, in the aggregate, considering the people that have non-recommended tests and those have only, it's about a 29% increase in the overall molecular spending. So basically, when you apply that to the numbers involving millions to tens of millions of patients, it starts to add up to some fairly substantial sums. So I think that our conclusion from this study was that these molecular diagnostic tests are being overutilized. People are practicing beyond what professional guidelines recommend. And there's significant variation between labs in the tests that are offered and performed. And there was one lab in particular that seemed to account for a large majority of non-recommended testing. So that would be an example of what I mentioned at the beginning of the talk of a niche lab that uses aggressive sales tactics to promote its testing and get physicians to order large amounts of tests that in this case don't appear to be consistent with what's clinically recommended. So how to deal with this? Well, overall, it has to be approached both through education of providers and then maybe with the sort of nudging of utilization management systems that will help to guide people away from these tests that are not clinically appropriate under these circumstances. Okay, so now a third area is cardiovascular disease risk testing. And I think, as we all know, there's a standard set of tests that's just done, and we've just had a research conference from our chemistry fellow talking about our methodologies for doing this and how that works in our system. But there are labs out there that offer expanded panels that they claim will improve the overall risk assessment or help on the choice of particular lipid lowering therapies, of which there are a variety of classes and individual drugs. So this was an area that we thought would be worth looking at because, again, this is a very, very common test ordered. Guidelines say to get this test every 5 years for adults above a certain age. So there's going to be millions and tens of millions of people who get this every year. So this was done mostly by Mike Astian. He's had an interest in this area for a while. And so he wanted to see that there is one of these labs that has a very, very extensive panel with lots of other tests which have to do with more detailed analysis of the size distribution of the lipoprotein particles, some tests that are genetic risk markers, and other substances that have been associated, at least in some form, with increased cardiovascular risk in some populations. But if you simply look at it from a clinical standpoint and say, how much value do these add in the setting of routine screening in the primary care population, they really don't add very much in terms of the ability to come up with a sort of useful risk analysis. And the cost, as you can see, the cost differential is enormous, that a lipid panel done an automated chemistry analyzer is quite inexpensive. And this particular lab is charging about $500 or so for the panel that they're offering. So we wondered, well, was this, that's the per test cost is high, but how much of this is actually going on, and is this actually a significant contributor to costs? So again, with our colleagues from CareCore and access to insurance claims database, we looked at this, and this just shows the results for a particular set of claims that we looked at that covered the eastern region of the country. So as you can see, there were in this population, which is smaller than that population that I mentioned for the previous study, this is the number of patients who had that test, and it costs about $1 million in that particular database at an average cost of about $560 per patient. So how much would this contribute in the aggregate? Well, if you then analyze this and say, again, kind of what we did with the vaginitis evaluation, say, look at all the visits and say how many have tests that are considered clinically appropriate, and then tests versus visits where there's some additional unproven tests or being ordered. So about 13% of the total spending for lipid cardiovascular risk assessment goes on these tests that are considered not appropriate for the primary care initial evaluation. And since cardiovascular lab testing is about 5% of laboratory spending, you can see that we're getting into, again, some fairly significant numbers when we extrapolate this to the national level. And finally, I'm going to turn to another area. So this is an equal opportunity talk. We're going to be looking at all areas of the lab, and those of you in hematology who thought you were going to get off scot-free are going to come under the microscope now. But more seriously, flow cytometry is clearly, it's fundamentally important now, and it's an enormous advance relative to what used to be done when things a few decades ago, it was pretty much all based on morphology and maybe a few special stains. So this is fundamentally important for the diagnosis and management of hematologic malignancies, and we've been fortunate in our department to have people like Brent Wood who have really advanced this the diagnostic potential of flow cytometry in a major way. But it's like any good thing, you can have too much of a good thing. And so this is a situation where it looked like it could be similar to CF, where maybe the billing system would be encouraging overutilization. Because, again, what you're supposed to do is there's a CPT code that you bill for each marker that you use. So if you did a test with 16 antibodies, you'd bill 1 unit of this and 15 of that. So that's technically compliant, but you can see there's no upper limit on what you can bill, so there is an incentive there to do more antibodies and build more antibodies for this kind of testing. So we wanted to look and see, well, again, that's what you might think just based on the theoretical analysis, and was this actually happening in practice? So here we looked at a database, again, a sort of nationally representative database, which there were 64 individual labs in this that had a reasonable number of claims for this particular CPT code. And so what I've done here then is just graph, each one of these bars represents one individual lab, and I've graphed the average number of units of this CPT code for flow cytometry that they bill per patient visit. So as you can see, it varies from a small number to a very high number. This little bit down here is actually not testing for workup of hematologic malignancies, so you can kind of ignore that. But starting somewhere around here, most of the testing is workup of hematologic malignancies in some form. And as you can see, most labs are somewhere in the 10 units to the low 20s, but we've got some up here that are kind of pushing the envelope and getting up to 30 or even over 40 in one case. So at face value, one would question whether you really need to do so many antibodies to work up every single case based on current best practices in hematopathology. So that's units. Now, what about the charge per unit? Because the total cost is going to be the number of units performed times the charge per unit. So this is what the insurer paid per unit for that code. And again, you can see there's a fairly wide distribution. In fact, the percentage difference between the bottom and the top is much larger than it is for the unit distribution. So again, most labs are down in the teens to 20s, and our lab is very reasonable. Our fee schedule probably would put us somewhere down, maybe kind of down in this range. So, but then there's some labs out here that have extremely high reimbursements, and so you really have to ask, is this lab up here really 15 times better than this lab down there? I kind of doubt it. So I think that it does look like some labs have been able, by various means, to get very high per unit reimbursement for this particular code. So basically, when you put that together and come up with a total cost per visit for this kind of testing, then you get a graph that looks like this. So this is dollars spent per visit for this kind of testing for a given patient. And again, it's the average figure for each individual lab in this data set. And you can see that, again, we're getting this huge spread for a lot of labs that are maybe getting a few $100 to $500 to $600 or $700 per visit for this testing, and then some out here that are getting considerably more, and one's getting up into the $2,000 to $3,000 range. So again, one has to say, is it really necessary to be doing a huge number of antibodies and charging a very high amount per antibody in order to do a good workup? And I think that our hematopathologists would say the answer to that question is no. So what to do about this? Well, I think that the data is clear on what's happening. And we've actually started to work on this just recently, and we've had some very helpful advice from our faculty member, Dr. Brent Wood, on how to approach this. So I think you could see this could be similar to cystic fibrosis, that if you keep the existing CPT code, you might say there are economies of scale. There should be some quantity discount, that the 25th unit shouldn't cost as much as the first or second or third unit. And again, there could be new CPT codes. As Brent pointed out to us, that there's already the professional interpretation fee for this is already tiered into groups that he thinks are reasonable. And so you could have the technical billing component that could be done in the same way rather than the single code with multiple units as it's now done. But this is also an example of a test where, while the per visit cost can be relatively high, as you could see in some cases running into several $1,000s per visit, pre-authorization is probably not going to be a particularly good strategy, because the bone marrow specimens are perishable. The patients are often seen on short notice for evaluation of a potential hematologic malignancy. So this is probably not something where we can necessarily say you have to get a pre-authorization before you can have this testing done. So those are 4 case studies, if you will, of what we've found so far as we've looked at this data set of insurance claims. And the overall conclusion then that I would say is that while it's true that molecular costs, test costs, are part of the cause of rising lab test costs, there's also a good deal of cost growth. which is due to tests that seem at first kind of simple garden variety tests that aren't that expensive. But in the aggregate, when they're widely used in the primary care setting, the costs really add up. And as I think I've shown that in the example of CF and vaginitis and cardiovascular risk screening, that application of existing professional society guidelines would result in considerable cost savings without compromising clinical care. But I don't want to leave you with the impression that all tests are being overused and that we just need to clamp down on everything. And I'd just like to give a preview of coming attractions in our series later on, where we'll be hearing from Dr. Colin Pritchard about a very exciting area in the laboratory of new molecular tests in molecular oncology. And it's true that just at face value, these tests are not inexpensive. But I think the key thing here is that these tests are useful in guiding the choice of therapies that are enormously expensive and don't work for all patients. So while we're not going to get a free pass on evaluation of this, and I wouldn't advocate that, at the same time, I mean, I think the figures are fairly compelling that the value to the healthcare system of these tests is very substantial. And this just shows our experience last year at UWMC with one of these tests, the KRAS test, which is used to help choose therapy for patients with metastatic colon cancer. And as you can see, our experience, which pretty much mirrors what's in the literature, is about roughly 40% of the patients have a mutation which makes them resistant to therapy. So basically we're saying that these people, that this therapy would be ineffective and have side effects for them and would cost in the tens of thousands of dollars. So I think this is an example of a situation where I think the laboratory tests, even though they are expensive, will be beneficial to the healthcare system. So now kind of going back to the larger society, and so we're going to go back to ancient Greece, and you're probably familiar with what happened to Socrates at the end of his life, and he was a distinguished philosopher, but at a certain point he kind of ran into trouble with the government of Athens, and he was tried and convicted of corrupting youth, and we would probably consider it a show trial in today's terminology. But anyway, so this is a famous painting by the French painter David, showing the cup of hemlock being prepared and passed for him, and his disciples are horrified that he's going to be put to death, but he was. So now I don't think I'm right now in danger of having this happen to me, but maybe if the Tea Party takes power and healthcare reform is repealed, that Dr. Astian and I will be offered a cup of hemlock. So the point is then that to the extent that policies that we're developing here are actually implemented in the healthcare system, there's going to be controversy and pushback, because some providers will genuinely believe that these tests really are useful to their patients, and certainly the laboratories that find their testing menus restricted are not going to be particularly happy about it. So anyway, but so looking at the larger picture then, really what we've been talking about are sort of really last-ditch mechanisms that the third-party payers can use, that the barn door is already unlocked, the horses are out of the stable, they're already galloping across the field, and the payers are just trying to put up a few barriers there to kind of stop them from totally escaping. So really, overall for the healthcare system, I think that it's going to fundamentally come back to what are the expectations of people in the first place. And this is obviously a difficult problem that goes far beyond the laboratory and is, to some extent affects all areas of the healthcare system. But particularly in the area of laboratory testing, I think it is important to emphasize that testing is not as necessarily as black and white as it seems, and that particularly in the screening or low prevalence test setting, that sometimes less is more, that if you do fewer tests, that you will end up with fewer false positives and fewer unnecessary workups and treatments that might flow from that. And then also, as I said, I think that the fact that for a long time health care insurance has been provided as an employer-sponsored benefit, so it appears that we're not paying for it, but of course we really are. So really, I think that is something that has to be thought about it in a more explicit way. And so really, but patients will need the education from knowledgeable healthcare providers, and probably some increased cost sharing would be a way of sort of bringing this to people's attention in the laboratory testing area. So in our setting here, I think it's worth remembering that actually cost effectiveness is already part of what we're supposed to be teaching and learning. So I've just excerpted one of the ACGME competencies in the systems-based practice setting, that we should practice cost-effective healthcare and resource allocation that does not compromise quality of care. And I think our department does a good job of emphasizing this in training programs, but I think there's clearly more to do. And there may be a sign that the medical establishment is taking this more seriously, and I would just direct you to a recent opinion piece in the New England Journal advocating more explicit emphasis on cost and value in medical education in all specialties. But again, I think in the real world that we need payment reform to really make these effective, so that there's a better alignment of financial and non-financial incentives to control costs in our healthcare system. So, and also to the extent that policies like what I'm describing are actually implemented, we'd need to have an evaluation to see are they doing what we intend. We would hope that by cutting down on unnecessary screening tests, there'd be fewer false positives and fewer unnecessary tests and treatments thereafter. But it's certainly possible that disease could go undetected or untreated if the policies become too restrictive in the other direction. It's certainly possible that changes in testing policies wouldn't reduce costs because providers will find new ways to get around the restrictions and maintain their revenues. And then also whether testing policies affect access to care. And I think, again, coming back to the molecular testing area, that molecular tests have generally been introduced fairly rapidly in this country, and you can make a good argument that that's worthwhile and probably will continue to be worthwhile. But there's already now discussions at the national level of sort of having a more controlled process that will control when and how molecular tests are introduced. So I think I guess we have to be careful that we don't go too far in the other direction and have to wait 10 years before we can start doing KRAS testing. So in summary, I would recommend that we make increased efforts to really integrate cost considerations more into medical education and our expectations for professionalism. And really, a lot of this, as I said, comes back to the larger society that we're in, that the idea that more is always better in healthcare is pretty well not supported by the facts and is something that we need to be more cognizant of. And then based on the work that I've described, I think it's possible to develop sensible testing policies that will be can be implemented in the real world of testing as paid for by third-party payers. And these are my acknowledgments. Thank you. Questions for Dr. Tait?
Yeah. John, in your analysis, did you break the labs down by their type, whether they're commercial, academic, hospital, and also the denominator of testing done at those sites?
That's a good point. That's something that we want to do kind of in the next stage of this is try to figure out, are there variables that can explain the variation that we're seeing. And so I think that I think sort of profit, nonprofit status would be one variable, and then the size of the lab and the complexity of the menu. So I think the answer is yes. it's worth doing that, but no, we haven't yet been able to get to that. Yeah.
Talked about coming at it from the insurer, from the patient side. When pharmaceutical costs got out of control, they actually came from the pharmaceutical side and actually sort of clamped down advertising opportunities, et cetera. Is this an advertising problem or is this a consumption problem?
Well, I think it's somewhat different from. Oh yes, the question is that when sort of overutilization became a problem in pharmaceuticals, that this was approached from the side of the pharmaceutical companies rather than from the side of the patients and providers. Did I say that correctly? So could that apply here? I think that that's perhaps less applicable here because there is a little bit of direct-to-consumer marketing in lab testing, but it's not nearly to the same degree of what's happened in pharmaceutical marketing. So I think in lab testing, the marketing is really from the labs to the providers taking care of the patients are the ones that order the tests. And I think there definitely are examples of over-aggressive marketing that's promoting over-testing of various kinds. And I think that that's something that does need to be worked on. But I think that the approach to that, since we're dealing with a relatively small group of providers, a relatively small group of labs, it's not really quite the same as having some sort of FTC control on direct-to-consumer advertising. So, but I do think that is something that needs to be worked on. Yes, Mark.
Very interesting talks. A few months ago, Atul Gawande had an interesting article in the New Yorker that explored regional differences in expense of use of expensive procedures and therefore the cost of healthcare in those regions. I think he actually picked on Texas and two regions in Texas in particular about that. But I wondered if your database has national and regional information so you can look to see if there are also regional differences. And part of his conclusion, I think, is that sort of the local culture of providers markedly influenced local practices, and a few leaders in the community or academic leaders in the community ended up largely governing the styles of practice in different parts of the country.
Well, I think that's a very good point, and again, that's the question was: are there geographic variations in lab testing that are attributable to differences in provider attitudes and the attitudes of opinion leaders in provider communities in different parts of the country, as has been shown for overall healthcare spending in recent articles by Atul Gawande. And I think the answer is, I think that this is probably here too, but we haven't really gotten into the data far enough to sort of conclusively prove that. But I think that clearly in some instances, again, if we come back to the marketing question, that there are labs in certain regions in the country that are fairly aggressively market within their region, perhaps less so outside of that, or that the providers near the labs become aware of the testing and order it more. So I think that is probably true. Technically, it's a little bit harder to do here because in these databases, what you have is the address of the lab service provider, but then obviously, as we know, specimens are shipped around the country all the time, so you can't directly say that a test done at a lab in North Carolina necessarily originated from a patient there. So I think part of what we would need to do to really do that is it would take a sort of a second, more sophisticated stage of data analysis where our colleagues at CareCorps would have to be able to go in and say, this test was ordered on this patient at this location in Missouri, even though the ultimate testing lab was in California. So, but I think that it's pretty likely that it's true. Yeah, Jim.
This is a nice study, John. They're very well done, very well controlled, it looked like to me. But lest we think that healthcare costs related to lab work is wagging the tail of healthcare, even if we were to eliminate all 4% of the lab costs, it wouldn't really have a lot of effect relative to the cost of administering health care costs, which is at least 25%, and I've heard one quote of 30%. And we're number one in the world in this regard. The closest anybody else comes to us is like 10 or 12%.
So the comment was that the lab test costs, if they only constitute about 4% of total healthcare costs, that even if we eliminate all of it, we won't be saving very much. And when you consider that healthcare administrative costs could be up to 25%, that maybe that's where we, that's a much bigger factor. And I mean, I agree completely with that. I mean, I think the definition of what's administrative is always hard to come by, but there's no doubt our system is rife with administrative inefficiencies. And if I was the czar of national healthcare, that's where I would start first, rather than sort of cutting the laboratory or other areas. So I agree with you. But again, I think it comes back to sort of one of my slides here at the beginning, as I think you have to sort of look at everything, and you have to start somewhere. And so granted, controlling some of the things we've talked about is not a huge contributor, but I think things will add up. And then also you have to consider sort of the downstream costs, is that PSA testing, for example, I mean, there's huge controversy about that. But I mean, if you believe the skeptics, and they will say, well, we're getting all these huge downstream costs of biopsies and surgery and so on. And so, I mean, I know there's people on the other side of that too. But I think what I'm saying is I think we need to look at this, but we won't expect this to be the solution by any means.